what I've recognized as a clinician, as someone who treats pain, is that our prescription options are almost as limited. We have some non-opioid choices. We have some what we call adjuvant medications like the anticonvulsant drugs, the antidepressant drugs, which treat certain types of pain. And then we have opioid and opioid-like therapies. So not a whole lot of choices. And usually what pain management clinicians do is rotate or juggle between the available options, and we combine that with non-pharmacotherapy, like behavioral modalities, physical and occupational therapies, counseling, which is very important. Most people, it's underrated just how effective these non-pharmacological strategies can be. Guided imagery, meditation, cognitive behavioral therapies. When it comes to the medications that we use to treat pain, just thinking out loud, I don't think there's a single one that's devoid of side effects. Every single medicine that we use has a side effect profile that we explain to patients. And that includes the class of medicines which have gotten a really bad rap called the opioid analgesics. Now granted, I think we kind of overdid it a little bit in trying to be good to our patients with using a class of drugs like opioids. And we learned a very hard and difficult lesson that there are some patients who just aren't good candidates for that class of therapy. Because although they're really a good class of medicines, they're a bad class of drugs for patients who can't control the use of their medications. And those patients go on to develop substance use, or what we call OUD, opioid use disorders. And we have more effective treatments for those, but once it happens, once that cat is out of the bag, it's a very difficult situation to control. So what we try to do as clinicians is maximize every possible therapy before we get to an opioid.